As I said, I'm Kevin Speer. I'm one of the orthopedist here, and I want to welcome you to our symposium. This is one of several that we've done. Thanks to Paul Salam for helping put this together and help organizing it. I hope you find benefits within it. I think that once the speakers, after my talk and after Paul's talk, we sort of are hoping for some discussion and some feedback. I think the scapula-based problems are the hardest challenge in the shoulder to me. And I'm going to sort of give you my perspective on how I approach it. Within orthopedics, there are some specialties, and orthopedics is specializing more and more. So shoulder is a specialty. It's my specialty. But even certainly in this region here, even amongst orthopedic surgeons who do a lot of shoulder, nobody wants to tackle the scapula. So the scapula is sort of this sort of enigma, and it can be challenging, it can be frustrating, but I think there is a sort of a approach, and I sort of take more of an algorithmic approach towards it, and I'm going to sort of share with you sort of how I approach it, and then we'll move on to Paul's talk, and he can show you how to fix it. When I see patients in the office, the front desk person will write shoulder pain. So most patients say, their shoulder hurts. And I said, well, so I always ask, so where does your shoulder hurt? And they point to the scapula. It's uncommon for someone to come in and say, oh, my scapula hurts, unless they have. Usually that's a signal that oh really? How do you know what a scapula is? So usually that's their shoulder. And I'm interested in where their scapula hurts. That's important to me in the process, in the history that I obtain, and I'm interested in having them point to it or have them describe it. And some of them, if it hurts enough, they'll point to me. Well, here's where I hurt. Are they pointing towards sort of the upper border of the scapula, back of the neck? Are they pointing more towards the medial border of the scapula, or it's sort of more pointing, towards sort of the posterior shoulder, the infraspinatus fossa area? Because in my approach, and much of this is leading towards making a diagnosis, but I am trying to make an anatomic diagnosis. If I can, then I think I can focus treatment. I can understand treatment options, prognosis, counsel patients. So I have sort of these diagnosis silos that I'm trying to deposit the patient in. Because if I'm successful with that, I think that their options for treatment, there's more clarity, not only for the patient, but for the physical therapist who's treating it in terms of this is what I think is going on. So sources of scapula-based pain. First off, and we're going to talk a little more in this minute, it could be the cervical spine. Referred pain and tenderness. Now, it could be the shoulder itself, the glenohumeral joint itself, or the subacromial space, which is important to know. It could be more the upper portion of the scapula, the supramedial angle of the scapula, an impingement. The eponym in orthopedics is used to call it a snapping scapula, or it could be more of a scapulothoracic bursitis, a bursitis between the serratus and the chest wall. And sometimes that can be crepitant down there as well. So, scapula-based pain. When someone is pointing to their scapular area, and especially if they're giving me this sort of posterior neck, upper medial border of the scapula, sort of in this area here, the first thing I want to figure out before I invest too much time figure out is this from their neck? Because, the posterior but first off, the cervical spine undergoes senescent changes as we get older. There's certain areas in the body that, as you get older, the x-rays change. Cervical spine is one. Shoulder's another. So you get disc bulges, you get osteophytes, you get little spurs. And Sometimes the facet joints, if they're arthritic, can refer back here. Sometimes the uncovertebral joints can refer. Sometimes herniated discs themselves. Now, many times a herniated disc, talk about radicular pain and pain going down the arm and all that. I mean, that may be more classic, but unquestionably, it is possible, to have annular-based pain, sort of herniated, either annular ligament tear or herniated disc, cause pain in that area. Ironically, or so incidentally, my colleague upstairs, who is a spine surgeon, describes, because I talked to him about this as well, about the neck, and he had a cervical a C5/6 anterior cervical discectomy infusion. His initial onset of pain when he herniated his disc, said it felt like someone took an ice pick right there, and it was not pain down the arm, not radiating pain, not radicular pain, sort of right the supremedial border of the scapula. So just in your mind, if patients have this sort of locus of pain, be sure it's not the neck. Could be the shoulder itself. Now, the shoulder itself, there's a couple things that really come to mind. One is that the posterior labrum in the shoulder, when it tears, and it's allowed to sit in the shoulder, has a unique predilection to develop a cyst, like a meniscus cyst. Now, the anterior labrum rarely forms cyst. I mean, they can, but it's unusual. Superior labrum, they can. But that posterior superior labrum can form cyst, and if they do, that cyst gets sizable enough, that can cause pain back there. So it's all of a sudden someone coming in to me has this sort of posterior infraspinatus fossa pain. I'm thinking maybe posterior labral tear, maybe posterior labral cyst, could be posterior capsular tightness. As Carrie was pointing out, a internal rotation defect. It's curious that, say, someone who has a loss of internal rotation, 40 degrees, clear defect in the posterior capsule, tightening the posterior capsule. Many times that renders more subacromial-based pain, anterior pain, lateral pain, impingement-type pain. Every now and then, it makes the infraspinatus spasm. And so sometimes, this is from posterior capsular tightness. Not often, but it can be. And again, if you have someone sent to you with this sort of locus of pain, you got to sort of figure out. And if the etiology ultimately happens to be that their posterior capsule is tight, and you go through this, therapeutic algorithm of periscapular and all the stuff that Carrie points out, that Paul's going to point out, and their problem essentially is that their internal rotation is tight, and for some odd reason they're having infraspinatus radiating myofascial pain, then they're not going to be getting better. So again, just a matter of being aware, especially in this area right here. So again, this is not medial border scapula pain. This is not supramedial pain. This is more infraspinatus fossa pain. Occasionally, atypical impingement. I have patients just for weird reasons. That's where their subacromial-based pain seems to emanate. But usually those patients are, overhead activity. They have a classic sort of a subacromial-based exam. It's just that their locus of symptoms is a little bit more posterior. If it's more supremedial scapula pain, it's going to be in this area here. So here's supremedial border of the scapula, up the lateral neck, up almost to the base of the skull, down in this area here, more the middle trapezial area here. Now this is more the supremedial scapular impingement. The eponym, orthopedics is rife with eponyms. The snapping scapula, so that someone has this crunching, popping, grabbing sensation. It's sort of the upper third of the scapula. That's what it is. A lot of people have crepitus back there to begin with, and it doesn't hurt. And they say, well, should I worry about it? No. I mean, to me, especially if they're really pushing me to give them some sort of analogy, I'll say it's sort of like the kneecap. Patella has condylomalacia degeneration. Lots of people have noisy kneecaps going up and down stairs, and if it doesn't hurt them, then don't listen to it. So I just tell them, don't listen to it, because some people just have noisy scapular bursts up there. And if they really, push me, I said, listen, consider yourself fortunate because you don't want to develop a pain problem in this area. It can be damn hard to get better. Very, very difficult. It radiates like the levator scapular radiation. There's one thing I just threw this in here. It's kind of unusual, but hopefully, there's something called a Klippel-Feil syndrome. You should at least be aware of it because what it is, when humans are in utero and very early on, maybe in the first trimester, early second trimester, the shoulder blade, the embryonic shoulder blade, is on top of what is the shoulder, like like a shoulder pad, a football shoulder pad or something. Then, as the fetus sort of develops, the shoulder blades descend. Sort of like how the kidneys move. It descends. If that descent isn't quite normal, the shoulder blade doesn't go quite down there, and these patients have a lot of issues. Now, usually these people are diagnosed early, by age 7. But if that shoulder blade looks a little funky, or it's not quite down enough, and all that, at some point it could be, that's what it is. Now, the treatment is what you're doing anyway, but it's helpful to have an understanding that there is sort of a developmental anatomic basis if the shoulder blade isn't all the way down where it's supposed to be. Usually the pain, supramedial scapula, snapping scapula stuff goes along the levator scapula, and it can be a lot of pain up here. And for people who are sort of prone or sensitive to headaches, all of a sudden they're describing all sorts of occipital headaches and headaches, the back of my ear, all sorts of stuff up in here. And you have to recognize sometimes that that's a radiating pattern up from the supramedial border of the scapula. Medial scapula pain. So they're pointing to the medial scapula. And, so I'm thinking more from the scapula spine down. The medial scapula is what hurts. Crepitus can be present. A lot of times I like the prognosis, I think, is more straightforward if crepitus is present because that means there's a mechanical component. When you deal with just pure myofascial pain and a little bit of dyskinesia and all that, that's tough. But when there's a mechanical component, there's some space-occupying bursal adhesions that make noise, and that bursal space is painful, then all of a sudden, there's something more to work with and get your arms around. So medial scapular border is another area that I want to be sure I understand. So to me, treatment begins with a diagnosis. My whole thought process is, can I put this patient into one of 4 or 5 categories of diagnoses or not? Because if I can, then there's certain algorithms, certain thoughts. I can communicate to physical therapists better. I can illustrate some prognoses, and if it's not that, I'll still get them in with physical therapy. But certainly in my mind, I'm a little bit more cautious about their prognosis. I mean, if they just have some bizarre non-anatomic myofascial pain, involving the whole trapezial distribution, it doesn't fit one category, it's chronic, man, that's tough. That's real tough. Real tough stuff. It doesn't mean you don't try to get it better, but I'm trying to find a source of it. So, based on the bony anatomy or the supramedial border or the medial border, how it affects the trapezius. And this is just something, more pictures later, but the trapezius is a major player as to why scapular-based pain is so difficult. Because the first trapezius, very big muscle, very flat muscle, and it's a anti-gravity muscle. It's a dorsal muscle. And it has a unique predilection. When the trapezius gets irritated, it can develop focal spasms, trigger points. Now, lots of other muscles don't get trigger points. Trapezius does all the time. And you see in some people, it is crazy what the trapezius does. And how do you undo that? It's tough. Massage, variety of techniques. Some work better than others. One of the things I really want to do with the scapular pain, especially if it's supremedial scapular pain, I want to be sure it's not the neck. And I've talked to, in preparation for this, I talked to a couple of my colleagues who do nothing but spine surgery. Both, well, one of them's a neurosurgeon, two of them are orthopedists. And I say, in my simplistic notion, I really try to keep things simple because it's just orthopedics, right? If someone has a supremedial angle scapular pain and it's wicked and it hurts and all that, and you're thinking it's neck, scapular pain from the neck is ameliorated to some extent with cervical traction. It's just that simple. And I've talked to some of my colleagues. I said, now, is that simple approach? Is that good enough? I said, yeah. I mean, you may not resolve it. So if you're really struggling, and I tell the therapist that, if you're really struggling, I said, let's try some traction. Does it get better or not? If all of a sudden, if I'm thinking medial border scapula and all these other, then the therapist says, traction really helps them. I said, cervical spine traction helps them. Then all of a sudden, I may be off base with my diagnosis. So I think traction helps. And plus, if traction helps, then more traction helps more. Meaning, PT, home unit, whatever. Because it may be just that simple. Because I'm looking for simple solutions to what can be a phenomenally challenging area of the body to render pain-free. Surgical treatment is very limited back there in the scapula. First off, for scapular winging, like Carrie pointed out, so here's here's the scapula here. So the inferior medial border of the scapula is coming off a chest wall, call it winging. That's a serratus anterior deficit, long thoracic nerve injury, typically. If someone has some wicked winging, and I mean their inferior medial border is coming off the chest wall, it's weak, the whole shoulder girdle gets dyskinetic, it's painful, it's rippling upstream into the subacromial space and all that. You say, well, if we could just get this thing stabilized, it'd be better. There's no surgery that's going to stabilize that. There's a number of things that have been described. Swinging the pec major back there, and a number of other things. Nothing really works so good. And then fusing it, bad option. So, someone who has a real long thoracic nerve injury that is complete and unfixable with scapula-based winging that's causing a lot of pain, that's an immensely difficult problem. I'll look for them and just, pray that, well, maybe the pec minor is so tight that, maybe by some anterior stretching that'll help. Or maybe we can try this. But many times, those are the patients that their treatment ultimately, activity moderation, thoughtful reconsidering of their vocational effort, pain management, it's not fixable. And nothing is ever so bad that you can't make it worse with surgery. Trying to route muscles to stabilize this thing down here, this scapula down here, just doesn't work. Now let's review the surgical anatomy of a few things that do work for surgery in the scapula. And just to review some of the anatomy, so here's sort of the central scapular spine, the trapezius. So think of the scapula and all the musculature. It's a tri-layer, 3 layers. I mean, the shoulder, the gluteal joint's tough enough. That's 2 layers, right? Deltoid and more like rotator cuff. This is 3 layers. First layer, trapezius. And so, it follows the ligamentum mutae all the way to the base of the skull. I think the general anatomic divide between what's the middle trapezius and upper trapezius is, I think, clavicle, so it's somewhere in this area here. But it's all a continuous layer. I mean, there's no raphe or anything like that. Surgery, they say, oh, well, here's the middle trap, and here's the, here's the upper trap, and here's the middle trap. The trapezius might be, average person, 3/8 of an inch thick, less than a centimeter. I mean, you could be a real big, thick person, heavy guy, someone my size or something like that, it'll be thicker. But for a typical patient and a small patient, it might be a 1/4 inch thick. It is a thin muscle. It's broad. It's like a big sheet. So, take the trapezius down, next layer. So here's the next layer. So the rhomboid is this huge, well, that's not huge, it's long layer of muscles going from the supremedial border of the scapula to the inferior, attaching it to the base of the scapular spines. The minor is the top one, the major is the bottom one. Hard to tell the difference between the two surgically because it's all a continuum, but there's a little bit of a raphe in there. It's a fairly short muscle. It just happens to be oblique, so some clever person said it looked like a rhomboid, so they call it a rhomboid muscle. Flat muscle, not very much. Terry's talking about how the rhomboids can counteract the deltoid and all that. I mean, the deltoid is 50 times bigger. The rhomboids have a central purpose, but they are unimpressive muscles to touch and feel surgically. They're short and they're thin. Maybe quarter-inch thick. It's hard to imagine that they have as much role as they do, being so unimpressive as they are. The levator scapula is what attaches to the supremedial border and radiates up. And this is like a T1 line radiating pain up. So this is why some people who get pain up in here and back of their neck come from the supremedial border of the scapula. So many times for me, if someone hurts in this area, and I'm going to say, okay, now, does your pain start here and go up, or does your pain start in the back of your neck and go down? Well, I don't know. And I said, it's important to me because cervical pain should have a linear radiation. If it's cervical-based pain, it's going to start in the neck. Why? It's cervical-based. If it's supremedial border scapula pain, it's going to start there and radiate up along the levator. It may even be in the end, it's the same cluster of pain. But where, from where does it go to where does it go is important, at least to make a diagnosis. And the notion of, is it cervical spine based or scapula based, that's huge. It's completely different in its diagnoses. The serratus, so attaches to multiple ribs, and it's a pretty good sized muscle once you add them all up. The serratus has all these little slips of muscles. It almost looks like feathers, and then you keep adding them up and adding them up and adding them up, and then eventually it's like, wow, it's pretty good, but it's a lot of little slips, and it attaches to the whole medial border of the scapula here. So it attaches over the rotator cuff. So the rotator cuff, subscapularis anteriorly, infraspinatus posteriorly, and supraspinatus more above that, are on the scapula. Then what wraps around that is the serratus anterior. And then when you go in there, between the serratus anterior and the ribs, that's the bursa. So some talk about the scapular bursitis, what's really between the serratus and the ribs, and it's a huge bursa. It's got to be, it's as big as any bursa in the body. It's usually about 9 by 7 centimeters. It's a big one, and all sorts of mischievous things can happen to it. When that bursa gets painful, like a lot of bursas in the body, especially the subacromial bursa in the shoulder, including the humeral joint area, it can be debrided. So if I can focus and understand that this patient's problem is a painful refractive subserratus bursitis, scapular bursitis, the pain's in through here, and especially if it's crepitant, especially if it's coarse, then that can be helped. That can be done arthroscopically. You could basically just debride the bursa out. You remove the adhesions. You remove the scar tissue. It's not terribly difficult to do. And if that's the problem, then you can really render some help. If it's not exactly the problem, then the outcome obviously is less certain. The post-op rehab is in these patients when I do an endoscopic, we call it endoscopic scapular bursectomy because it's not arthroscopic because it's not a joint. So in order to sound smarter. I call it endoscopic, but using the arthroscope. So basically, you put here's the scapula here. You put them in the chicken wing position, which gets that medial border up, and you got pretty good space in there. And one portal's here, one portal's here, and basically it's a little bit daunting. You're visualizing the rib cage, and you're moving all the bursa on top of it. These patients are out of a sling in 3 days, and a bursa this big, when you remove it, it's raw. It wants to scar back down. So what do they need? They need PT early, fast, and often. And so adhesions don't reform. And one of my good friends and colleagues and mentors to these two younger therapists, I had a patient recently. She's an 18-year-old girl who had bilateral crepitant scapulothoracic bursitis. Why? Who knows why? She had been through myriad of treatments and all that. They sent her to pain clinic, but essentially she had a very focal problem that once you got beyond why she had it, and the one thing that really helped her post-operatively, we did endoscopic scapular bursectomy, and if you ever have this, is think about this medial border here, trying to get it and pull it up off the chest wall, almost like you do all that, analogous to a manual distraction in the glenohumeral joint. I think that sometimes that seems to help, and it may not be the moment of greatest experience with the patient in the PT clinic that day, but I think there's value. It's not particularly hard to do because getting that medial border up with the arm behind the back, it's just a matter of value that there may be some distracting that bursal space may have some therapeutic benefit, and I'll be interested to hear if anybody's ever done that. Here's the big surgery. When the supramedial border of the scapula is crepitant and painful, a snapping scapula. The supramedial border of the scapula here is concave. It wraps forward. Sometimes it wraps a little bit too forward. That area becomes an impingement area. And you have to do several things there. You have to, basically the surgery is to get down there and remove this piece of bone. It's like an acromioplasty in the shoulder. You got to remove the bone that's impinging on the rib, and then underneath it, there's this plaque of bursal adhesions you remove. That's the objective. It's getting there. That's the hard part. Because getting there, you got to do first, you got to split the trapezius, layer 1. Second, deep, you got to start detaching things off that supramedial border of the scapula, as you see here. So you remove this piece of bone here, which the body's not going to miss that piece of bone. So removing that little piece of bone is of no consequence. It's just the consequence of the surgery is what has to be done to remove the piece of bone. So posteriorly, you're releasing the supraspinatus off of it. Medially, you're releasing the rhomboid minor and major off of it. Anteriorly, the serratus and the subscapularis, just to expose the bone. Then once you do all that, and then you can get to the bursal space and debride it, then you got to repair it. That's the challenge. That's the challenge, because you got a bunch of muscles that are thin, narrow, with unimpressive tendons, and you got to get them all pieced back together. And so you're repairing supraspinatus, levator, rhomboid, serratus, and subscap all into one construct. And getting it, and if it heals properly, it can be a very effective surgery. If it doesn't heal so properly, that's not so good. So these patients are protected. These patients, in my practice, first 4 weeks, they're in a sling and a scapular brace. Second 4 weeks, they're out of a sling, scapular brace. I don't start PT till 2 months. So, which means I am inviting scar tissue. I'm inviting weakness. I'm inviting all sorts of stuff. But I'm assuring that these tendons are going to heal. And I tell the patient, I said, look, it may require more therapy and more time, but we cannot allow the upper third of your scapula to have a non-anatomic healing position. These garment braces help, I think. Sometimes if you get them too tight, or patient too tight, they're going to self-correct and they get some numbness and all that. But they help to pull the shoulder blades back. But if they're a perpetual, constant reminder that you have to keep your shoulder blades back. You have to have better posture. And some people it's more important than others, and they're going to wear that for a while. I'm sure all of you are aware of these braces, and there may be, I would imagine there's some others like them as well. But I think they're an essential component, because a lot of people, their habit, it's like some of you, sit there, you're sitting there and, you tend to slump forward and the shoulder protracts a bit, and that puts a linear pull on the operative repair of a tissue that is not very stout to begin with. And that thing becomes unattached or thinned out, and all of a sudden the rhomboids aren't as strong. So it demands the surgical repair, and there's a couple ways we can repair them. I favor sewing the tendons to themselves, because it's more of a rapid healing. But still, there's a lot of protection involved, and it seems like every few years I'm protecting them more than I did 5 years ago. So in summary, the way I approach it in a patient is I want to make an anatomic diagnosis if I can. I think that the shoulder itself is amongst the most rehab-sensitive areas of the body, essential to physical therapy. The scapula may be the most rehab-sensitive area of the shoulder. And it behooves you to understand where the pain is coming from. Numbers are thrown out in orthopedics that 95% of scapula pain is secondary to glenohumeral problems. And that might be true. That might be true. But what we're not dealing with is something that is a chronic glenohumeral-based problem, that there's some scapula dyskinesia and weakness and all that. We're talking about real primary scapula-based problems. I think PT is critical, and also not only for PT is critical for therapeutic efforts, but also, which is just as a part of your profession, these patients need to be educated. How do you sit? How do you work at your workstation? You may do all these proper things right, and then they sit at the workstation and they're reaching too far forward. The ergonomics of their workstation are improper. There's 1,000 little things, and much of it is how much you have to discern to inquire or help is pain. There are many people who have terrible posture and sit improperly, and their shoulder blades don't hurt. Well, good. That's okay. Then move on. But it's when it does hurt, then all of a sudden you're saying, "Gee, we have got to get you upright. We got to get your scapulars retracted. We got to be sure you're not tight in the front. You got to be doing daily stretching. You've got to rethink your workstation." Well, I can't. Well, if at some point you keep reaching forward, and after half a day, your shoulder blades are killing you, and then the pain cycle gets initiated once again. At some point, you're gonna have to recognize that you've got to do something to stop the cycling back there. And sometimes it's easier said than done. But I think that the education and reinforcement and the postural and their body habits that you all observe are critical, especially when you observe something that might be materially impactful to their clinical outcome. And then you got to start fussing at them about improving themselves, which, as we know, is easier said than done. So, next, bring up Paul Salam. We're going to talk more of the therapeutic aspects in when the scapula is dysfunctional and painful, and then that will sort of engender some opportunity to have questions and other observations, and we can have some discussion about the scapula and hopefully learn something from that.